So it is me again back with you all, and I actually have the great pleasure to introduce our next panel speakers. And this is we're going to be really concentrating a bit and hearing from this great group about just some different strategic opportunities now and as we begin moving forward. So I'm going to just introduce who's on our panel, and it'll also be the order in which I'm going to be asking them some questions that they have had a minute to look at. First, Latoya Chansey. She is our IDD team lead with the Division of Mental Health and DHHS. I've had the pleasure of working with her in a variety of different ways, and I am a huge fan. If I had one of those big lighters, I'd light it right now to her. I just aged myself. I'd also like to introduce Andrew Clendenin. Am I pronouncing your last name right? Wonderful. And he is the Associate Director for Behavioral Health and Community Liaison for United Healthcare Community Plan. So we're glad to have you here, Andrew, as well. Stacy, we want to thank you for filling in today. I'm excited to hear what you have to say. And this is Stacy Sorrells, and she is with the Member Relations Director with VIA Health. So we're thankful to have Stacy with us. And then Dr. Gary Maslow, who has had his pinky toe and all kinds of parts of Gary that we've all been pulling on for the last several years. So I'm excited to have him talking with us all as well about much of this. And Gary is the Associate Professor of Psychiatry and Behavioral Sciences. He's also the co-director of Child and Family Mental Health and Developmental Neuroscience and the Assistant Professor of Pediatrics. All right, you all ready? We're going to go ahead and jump in. And Latoya, I'm going to start with you. When you think of family support, my eyes, you guys are gonna have to see my profile so that I can see things a little bit, better. Latoya, family support is a more established service within the mental health community. How can we advance this service for those with IDD? What a loaded question.
Yeah, so there's a lot in there.
Yes, there is.
So many of us on this call, we're aware of how important peer support is within the recovery process for individuals who are experiencing mental illness or substance use disorders. But we're also seeing an emergence within the IDD community in various ways where we're seeing a similar need to come through, that is coming through for the individuals who have IDD, but also in the form of family navigation as well. Particularly here in North Carolina with our community partners, we're seeing projects like the North Carolina Navigating Care, the ECHO work that's happening with the Mental Health Home Initiative, in lieu of services like what Trillium has implemented. And then we're also seeing where we can learn from what other states have done. We're following states that have it as a part of their waiver services, as well as offering it through other types of supports and programs for that as well too. What I think that we're seeing an increase in desire for is more active engagement with our self-advocates. We've seen this happen before with the North Carolina Council on Developmental Disabilities with their previous initiatives. But self-advocacy is so important because oftentimes within the IDD community, we hear a lot from our families, which is great because we value the input that our families are providing because they're essentially frontline, right? So within this, we do want to form different ways within North Carolina where we're having an opportunity to hear more from our self-advocates. Now, through hearing more from our self-advocates, I think it gives us an opportunity to then allow others in the community to hear their voice, see the need, and recognize the importance to be able to build upon what's already been established. So I think we can advance this goal by strengthening self-advocacy efforts in North Carolina. I think that's going to be one of the key pieces to help this be to be successful. And then also when individuals in the community are able to see that emergence of individuals with IDD advocating for themselves, and also across the state. Because oftentimes too, we see things kind of centralized within our triangle region, but we want to see advocacy across the state. And then also with our families, continuing the expansion of the work that's happening with family navigation work, through the identified curriculums. What we can then do is similar to what happened with peer supports with mental health and substance use. They were able to provide evidence to go towards the efficacy of the need for those types of models. So that's why I'm going to pause.
I really appreciate your point of view, Latoya, and I know you two have been able to experience some of the other projects that have been happening across the state as well. I'm going to say, just as a parent, what's awesome about the involvement and making that emphasis on listening to our self-advocates. My son doesn't have that way of communicating. And so often I see those that are able to communicate, that's the voice for a lot of our loved ones who may not be able to articulate that. So I really appreciate that perspective. Does anybody else on the panel, not that we're all panicking, anybody else on the panel have anything they'd like to add to what Latoya said before we move on to the next question? Okay, we'll just keep plugging forward then.
Kim, you muted yourself.
Thank you, Latoya. Andrew, given the positive response to family navigation services within the medical home, what steps can we undertake to broaden that implementation?
That's a really good question, and I think I compare it a lot to our efforts to integrate behavioral health services into primary care and other medical settings. I think it starts with developing and sharing the value proposition. So I think it's emphasizing the value add of family navigation services, and especially when you think about like the quadruple aim of healthcare, improving ways to improve patient experience, better health outcomes, and then improve staff experience and lower cost of care. I think for this type of opportunity in the healthcare setting, it's really emphasizing the better patient experience. It's involving the family along with the healthcare providers, which then I think improves the healthcare providers' experience as well. And then this sort of secondary to that is the better outcomes, and not or I should say secondary to better health outcomes is the lower cost of care. And so I think from a health plan perspective, like I work now for United Healthcare, we need to look at more innovative ways to make sure that we're engaging our members, that they are able to navigate this very complex healthcare system, and it's only going to get more so over the next several months and years. So I think that's where I would start, is just as a group of advocates that we develop and share that value proposition. And then would say that beyond that, it's really looking at the medical homes. It's looking at healthcare providers who are interested in offering services like this, and helping them assess where they are in terms of readiness to provide these services. Taking an organizational assessment, and looking at is there a need? Is there the capacity? Are there the resources that they need in place to begin providing the services to their patients and to their families? And I think so part of that is are there barriers in policy and payment that we can advocate for change? are there barriers in terms of workforce development and educational needs? Is there a way to develop a standardized training program that can be deployed statewide with a set of core competencies that can be shared across all the entire workforce? And then I think it's just the last thing I would say is this, making sure that all of us as stakeholders are aligned, we have a shared vision, and that we are aligned with efforts that are ongoing with payers, with the state, and with providers to make sure that we are tearing down the barriers. We aren't the barrier to these services being delivered.
Thank you so much, Andrew. And even just some of what you talked about, which is fantastic and truly what will be needed to help, push a lot of that further. When you talk about the barriers, is it being around the table at like summits like this, or it's how can we all, kind of come closer together to make sure that we are, like you're saying, all are kind of on that same page, that, in initiating just how, pushing this forward, that everybody's not kind of siloing and after different things that really are a lot of the same things. Do you have any recommendations for that?
Yeah, I think we, North Carolina has a great history of being innovative, especially in Medicaid and in our underserved populations. I think, though, what has happened is, we come together in groups like this, we share ideas, and then we go back to our individual areas of practice or work, and we don't really, carry the, in terms of eliminating barriers, we don't really educate those that need to be educated. So we talk a lot amongst ourselves, but we sometimes stop there. And I've found that in advocacy work in the past around behavioral health integration, it sometimes takes going to policymakers, payers and whatnot, and educating them, and sharing, again, what we have talked about together, and then corporately going to them as a unified force, so to speak, and really pushing for those changes in policy and payment, which oftentimes are the barrier to these types of services.
Really great input, and I'm trusting Karen and Christy are taking fastidious notes. Karen is the master in getting the right people in the right place, so I'm sure she'll grab that gauntlet and help us get that move forward. But Gary, I'm going to put you on the spot for a second as somebody who actually has a practice navigator involved. Can you just talk a little bit about how that's changed the climate within the practice? Because I even think about, you're having to transition from, and I remember some of this was talked about even in day one, from a pediatric practice, and then it's this whole new world of transitioning into trying to find adult whole care. And maneuvering that. How are you seeing even just the change in having a practice navigator embedded? What are you seeing?
Yeah, no, I think I appreciate what Latoya and Andrew are saying, and one of the things that I was thinking about, Kim, was the difference in my own practice and my own understanding of these issues by having someone who lived it in, as a part of our team. And I can kind of mark, before I started working with Marlon Wells and she basically forced her way as a volunteer at a clinic, there's kind of like how I practiced before having a family partner, and then and how I've practiced since. And I think we've had up to 4 family partners in different clinics that we really really value. And I think the before and after for me comes back to this issue of visibility. And I think you mentioned your son's voice, and I think as someone, a pediatrician, child psychiatrist, I came here, and for 5 years I didn't know about the innovations waiver. I was a specialist in primary care, seeing kids with developmental disabilities as their primary care doctor, and I didn't understand the service array. and that's not unusual. And I think that without the expertise of families embedded and as a part of the medical team, there's a lot of blindness, and it's blindness to the resources, but I think there's also blindness to an inability to know who is affected. You're not aware that you have a patient in your practice that actually could benefit from a service because you see them once a year and they're doing okay, but you may not be aware of all the things that are going on, in the background. So, we looked at again, as part of having a family partner, we actually reviewed all our administrative data to find out how many patients with autism and intellectual disability we had, and there were 500. And of those 500, most had never been screened by an LME MCO for eligibility for the waiver. Most were not getting behavioral health care. Most were not getting IDD services at all, like 80%. And so I think that's the hardest thing for me, is that without having visibility, we're only focusing on the outcomes of the people for whom we actually know about. And I think that's where, and again, those are often patients who are white, better off economically, speak English. And so for me, having a family partner who could support a Vietnamese immigrants, a woman who immigrated from Vietnam, spoke only Vietnam, some dialect that I don't actually know how to say, and had a daughter who was 18 and had, very impaired with autism, to have someone who could actually spend 6 months and multiple hours to connect this family to the service they need. It wouldn't have happened, and it hadn't happened for 18 years till I met them. And again, if I hadn't had a family partner, it probably still wouldn't have happened. So I guess I think it's a really good question, because I think it's sort of what I've been reflecting on throughout these two sessions. Is I think we'd like to have a before and after, where we have a system that really has family voices embedded in all aspects. And then there's the before, where we have lots of wonderful work going on, but it's not all in the place where it's not at the scale that it needs to be to reach all people. So yeah, thanks for asking that question. It was something I was thinking about, so I don't know how you knew that, but thank you.
We've worked together too long. We actually had somebody that was participating in another project that we haven't talked much, in the couple days, this, a family navigation project that, Tamara Norris and a few others are also engaged in. But we had somebody, her name's Jennifer, and she actually was working at a practice, and they just started to have a practice navigator there. And she said within 3 months, she said she was astounded at the change in the overall practice. I think there's also some level of guilt, because so many, the nurses and different folks they're trying to rush from one patient to the next, and they want to do these things, but they're not sure what it is, kind of to the point, like you said, Gary, that you didn't know what the innovations waiver was. But just how that was lifted, and just the change in the practice, she said it just was amazing to see that. Stacy, we're going to go ahead and now put you, on the forefront now. As you're looking toward the tailored plan launch, which we kind of are already very much so in that with our standard plan, but when we look at moving toward the tailored plan launch, what policies and strategies do you think could be put in place to advance family support and navigation?
Thank you, Kim. So I hope that we could think about this, and I could explain this by talking about some visions about where we're going under tailored plan, and then maybe circling back to some of the things that we're doing now that, of course, we hope to retain. One of the greatest surprises that I have had when reading through the expectations for tailored plan was the robust support for a system of care. And if you're not familiar with the system of care framework, I'll go over a few of the goals of that whole framework, but really and family driven, which is, what we've all been talking about and learning about. It focuses on those two things and also service coordination, strength-based and trauma-based informed care, care that's culturally competent, and stresses family involvement, not just in the process, but also really emphasizes family involvement in policy making on the local and state level. So those are some of the bigger goals of the system of care framework. And, when we think of that whole framework, what does that look like out in the real world? That, and this is really great news, that means more people out there doing that work, more family partners, and more system of care coordinators. So that is where we're headed. And, we are working really hard to meet those expectations and get everything in place to be able to do that. So the goal would be that we would have more family partners, more system of care coordinators out there in the community. So they would work directly with families. They would definitely be involved in the community collaboratives, out there establishing connections, making sure that they're really the great connectors. That's what I always refer to them as. They help connect the dots for families and for agencies that need that assistance. And they also help improve the system because they're out there listening to the needs that get mentioned in these settings. Right now, VIA currently has an SOC System of Care expansion grant, and those goals go right along with what we have seen laid out in the RFA. They're one of the biggest goals for that expansion grant is to increase family participation, address health disparities, and then increase and develop trainings that meet the needs of families. So it's all about family-driven care. So that's what our goal is to really harness the power of those community collaboratives, of those family partners, to identify needs and then work to connect all the dots. I'm really proud of VIA's commitment to family support that has already been shown. We have family partners on staff, and I have the pleasure of working with them. Julie Davis, who you heard from earlier, she's one of our rock stars. And so I think that model of incorporating family partners into our care management process, we've definitely already been doing that, but we hope to really shore up those links, and they are part of the team. And believe me, they get called on to be part of the team all the time. We also, and this is a personal passion of mine, really are strongly committed to listening to the feedback of our stakeholder groups. And then not just listening, but then communicating that feedback to where it needs to go. And that is definitely something that will continue after Taylor Plan launch. Also, I think it's important that we continue to support the development of family partners and family support within some existing services. We have an Outpatient Plus service that actually has that as part of the service. So that's very exciting. Continue to support models like you heard from Samantha for the DD Plus, where those services are within the medical settings. And then continue, of course, to foster the development of new to us at least, projects like the ECHO project. So we're very excited about the possibilities in the future to really get in there and do some work and expand the family support.
Thank you so much, Stacy. Really, you know, I like many of the points that you touched on, you know, personally, and you know, you're here representing, you know, kind of the MCO point of view, and I know it's, you know, via, you know, what you all are doing, which is great, and we've really enjoyed working with Julie as well. So, but something that comes to mind, and it was something I just touched a little bit on in our earlier presentation, and what I want to put out to the whole panel, that I know there really are some strong supports for our mental health community. Not that anything can't be, you know, better. This isn't, you know, I'm not meaning that. But, you know, around mental health and substance use, you know, how about though, you know, I'd love to hear just how you all, when we're trying to take a look at family support and for the community, the IDD community in particular, how do you see what is needed and help pushing those initiatives forward? So I'm going to put that out to all of you. I don't know if somebody has an actual idea on that, or dare I put one of you?
I can throw out an idea.
Okay, LaToya.
What I have noticed, you know, like for instance, with some of the work that Dr. Christian was doing with the complex needs clinics and looking to expand to some of the other ones, is sometimes what happens is when it happens, and even what Dr. Maslow was talking about earlier, where when you see the benefit of it in action, it makes it easier to actually report out to others that this could also benefit your practice. This could actually benefit less crises calls and more ways of being able to find some all around supports, because we know that, you know, certain doctors' offices are only able to do certain things. And so instead of it trying to fit it all into thinking that the one doctor can fix everything, having a robust system of care that can be better established by actually having someone who is able to talk about it from this navigation standpoint. But I think sometimes what happens is people need to hear that it's working and see data to support this is actually working in our practice. You should consider it, and then it starts to kind of spread from there. I just feel like sometimes in North Carolina, that's what ends up happening, is like it starts in one place and then it just slowly spreads and spreads and spreads. So I think something like that could help, is trying to find and strategize a way to get the information out to more primary care offices and other offices that support folks.
Great.
And also, LaToya, I think you mentioned this before, we really have a roadmap, what we've seen happen with peer support. You know, I think that provides a good roadmap for what could happen. And we've seen a greater acceptance, and you know, now that is just part of what we come to expect.
Yeah, and it didn't start that way.
No, it didn't.
So yeah.
Great input. Andrew or Gary, do you have anything you'd like to add to that?
I mean, I think the analogy makes sense to me, and I think we kind of divide up problems that happen in people's brains into mental health, substance use, development disability, neurological. But it's all the same person brain, and so if it's a useful service for one brain disorder, it makes sense it would be a useful one. And I think that that's where these are arbitrary distinctions. I don't know how, again, I'm not an expert on how you make that policy change or how we get the advocates, as Andrew was saying, all together, and the gradualness of this. But from a medical and logical standpoint, I find it very confusing why you'd have a definition that somehow someone who has autism is that dissimilar to someone with schizophrenia, and you can have one service if you have one condition and you have one service if you have a different condition. That to me is confusing. So anyway, that's just my kind of logical, simplistic approach. But again, I don't know how we actually communicate that in a way that makes a difference.
Great, thank you all.
Yeah.
Andrew, did you have, yes, Andrew, please.
Yeah, real quickly, I was just going to mention that I think with our move toward, pay for performance or, value-based payment models, just kind of brainstorming right now, but I think someone mentioned in day one about how you don't need certain credentials or a degree or to be considered, good at your job, so to speak. So I think when I think about opportunities for practices who want to implement family navigation services, I think there's an opportunity as we launch into value-based payment models for providers to use some of the funds that come their way to invest in these types of services. So it may, and not that we should bypass any policy changes or payment reform, but that might be one potential area that that providers can be looking at and to maybe sooner than later be able to invest in these services when they think about it through the lens of value. So I think just a brainstorming moment, but I really don't want us to get caught into a situation where we wait for years for policy to change when it may not happen that quickly.
Really, really great point. And I'm going to throw a question back to you, Gary, here for a second. Just wondering, why Duke was willing to, to pay or move towards having one of those practice navigators. Like what helped drive that decision?
I mean, it started like many things with grant funding. We had actually Marlon volunteered, so I didn't have a choice. She just said she was already a Duke volunteer and she was going to come to clinic. So, so I think having strong family partners before you even have a family partner program, you need, I think having dialogue between practices, payers, everyone. If you don't have family voices, you don't know that you don't have that. So I think that was one thing. And I think, we've essentially been holding it together mostly through grant funding. I think we are getting to a point where there is recognition as part of some of these care management per member per month things that this is something that it has value outside of the funding mechanism. But I do think the barrier most practices have is how does this fit in? It's not if you can't bill for it, could it fall under per member per month payments? But if you have, again, we have a very high Medicaid population. So for our practice, it actually will make sense in a place where we have per member per month. But I think it's just very hard in an environment where there's so many different payers and everyone has their different program, and how do you actually sustain something if it's not more uniform? So I think we've had leadership support and we've had practice level support, and people have seen the value, and so I think those are key. But I think it's possible to do in other settings as well.
And I know we heard from Dara earlier as well, and she and I've had some conversations. But even within your practice, how are you all collecting data to maybe even show these positive outcomes? Is that something that you all are actively engaged in?
Yeah. So we have a few different things we're doing, and then we have things we'd like to do. I mean, I think if I were to step back and say, like, what is a way, if we all could come up with essentially a research network, essentially for family interventions, and basically we could you do that in other settings, right? We study different medications or treatments. You'll have multiple practices or multiple organizations that have a shared data system. And so you could imagine that every family that's a part of one of these practices or part of the system, every family that gets connected to a family partner would have the opportunity to participate in a study. If they wanted to, they wouldn't have to, but that would be an opportunity. And there would be common data elements we would collect about why do they agree to do why do they want to have a family partner, information about their child or their experience. And then we could capture what they got from the family partner in terms of from their perspective, and the family partner what they did, and then be able to survey them periodically about change. I think that has been very powerful, that kind of approach of using real world interventions that are happening but having common data elements. So either you have a centralized data system that is sending out surveys, or you have each site doing it. It is infrastructure that we'd have to figure out how you set that up, but it is something that's done for many other conditions. And so that to me would be the question you had sent ahead was kind of how, like, what should we do? And I think that would be a pretty novel thing if every group that's doing family partners were to come together and say, these are the common outcomes that we're looking for, and this is who's doing the work and how it's similar. And then we could really see what happens to people who got that, because there is this amount of family partner work that's increasing and family support that's increasing right now. And so you really could have a very powerful, relatively rapid data process that could then be used as part of the justification and for the value of this to the different stakeholders. So what we're doing is we're basically, the family partners are documenting what they do, we're tracking that, and then we're doing interviews, qualitative interviews with family partners about what their experience is, and then with families that have received it. And then we have one study that's more formal, where we have it's a complex care intervention that is being led by one of our pediatricians, and there's a family partner on the team, and basically all the caregivers who are enrolled get surveyed. They do surveys at the beginning and then every 3 months for a year about their activation, their how confident they are in their own ability to navigate the system, care fragmentation, and several other important outcomes that are really child and family centered. And so that's a pretty formal evaluation. And then lastly, we've been putting in grants and trying to find ways to fund a randomized controlled trial where you basically, one group gets the family partner, one group doesn't, and you see, how that affects really important outcomes. I think the notion of value to me is where it comes back to. And if you're just tracking the people who get the thing and not the people who don't, you're actually missing part of the equation, because there's a group of people who just won't raise their hand for it. And then there's a group of people who aren't even in the system enough that we would even know. And so I think that's part of what, to me, figuring out ways to study and support the less visible parts of our system seem really important, because we talk about the waiver group, we talk about the group on the waiting list, but there's actually the group that's waiting to find out about the waiver, which is actually probably like 3 or 4 times greater than the group that's on the waiting list, right? So that group that's waiting to find out about is actually the one that I would say we should all be thinking about a lot, because from a value-based perspective, they're the ones who have a very poor experience in the system. They're the ones who probably actually have very, very high cost, because they don't even know what to do when they have a crisis, or even but there is a way to support them. And certainly that's challenging for providers and the other parts of that. I think, Andrew, the quadruple aim, that's the group to me that the ones people have identified, we can support them in the quadruple aim, but it's that group that have not been raised to the system's view that and ultimately I think we need to study who benefits with what type of family support, because some people need something intense, some people need less. And then what is the mechanism, and ultimately how what is the time horizon of that value proposition? My failing for 5 years to identify patients for the waiver cost those families, in terms of services that they didn't get, they're not going to receive for a period of years, millions of dollars, right? Like literally those families, by not getting on the waiting list earlier, are going to be many years behind in getting those services. So that family has lost, financially because of that. That child is lost because they didn't get identified. But if our time horizon is next year's revenue cycle, or like the 2 or 3 year grant cycle, I operate in 5-year grants, 3-year grants. That's actually probably not the right time horizon. It's really this 10-year, transition to adulthood. So that's a lot to say. I think the idea of working together and collaborating and how we can evaluate and really demonstrate with really solid evidence that this is a priority and that how this works, I think, is really important.
Great. Thank you so much, Gary. Anybody else have anything they'd like to add, or something that struck you while Gary was talking?
I'm always a fan of the data. So just the different methods though, I think that is awesome to that the way that y'all are gathering the data is not just the one method. You talked about at least three that I picked up on of how you're picking up data from to really see and be able to have something to measure what's working against.
I would agree with you, Latoya, and we think of just some of our different family groups, and they're not going to fill out a survey that comes to them, through email. And sometimes it is, trying other methods, is it getting that call from somebody and actually talking to them on the phone? And then even then you're able to find out just even some more of those different barriers that they're facing, things that they didn't even know they could ask for, or didn't even know what they don't know. I mean, we say this all the time, that comes up. Gary, take a sip of water, because you still have the last question that I'm going to go ahead and pose to you. So we did talk, you did touch on this last question a bit. So just in case you had anything to add, or anybody else on the panel as well, what research is needed to advance family support and navigation within the health system? And I feel you did touch on a good bit of that in your answer. Was there anything in addition that you'd like to mention? I'm going to even kind of, just talking to somebody who has that lived experience too, and how that brings down some of those walls, and just that deep breath you can almost hear on the other end of the line. So I don't know if you had some more comments, Gary, you want to put on that, and then open up to just some final comments from the panel.
I think that in the chat, there's been a bit of a discussion about the known that peer support is actually something that has a pretty broad literature already. And so I think that, to me, it's being able to point at that broad literature for peer support that already actually other states do this. It's actually not that complicated. It's being done here. So I think that, to me, is one other point to say, like, we actually have a robust literature of this outside of North Carolina. And so applying it in the North Carolina context is obviously different, but I do think the research data, there's a lot of information of that. I think for health systems, if we're really in a value-based environment, what better way to help people have a better experience of healthcare than to have family support embedded in our system? So if you're a parent coming to the hospital and you can speak with someone who's been there before, you're much less isolated than if you're there by yourself. And I think that idea of this is the right thing to do because it's the right thing to do for people and for care. How we finance it, how we demonstrate value, I think is a challenge, but I think there's a lot of face validity, research validity, and then experience in North Carolina to say this really should be broadly available. And I don't know how we fully get there, but health systems, I hope, will be embracing that.
Great, thank you, Gary, really appreciate that. Latoya, I didn't know if you wanted to maybe even talk for a quick second about the new stakeholder group that kind of crosses over systems. And then we do have a question too that Holly Connor posed as well that I'd love to throw out to you all. Latoya?
Yes, so in partnership with the Division of Health Benefits, or NC Medicaid, Kenneth and I have launched the DHHS IDD Stakeholder Work Group, which pulls together representatives from individual self-advocates, family members, and we were strategic in trying to get family members who are accessing state-funded services, who have the waiver, and then those who may be accessing other Medicaid services as well too, so that way we're not just hearing just from our waiver families, or just from families who don't have services. We want to make sure we're hearing from all of our families. We also have representation from direct support professionals. Oftentimes when we get into some of these work groups, their voices are not always there, so we have them. We also have provider organizations representing residential providers, community-based providers, as well as those who do things like day programming, autism providers. Then we have some subject matter experts, which kind of goes into the question, but it does include representatives from DPI, our Department of Public Instruction, as well as our Division of Public Health, because our Division of Public Health is actually, they're the ones for those services for 0 to 3. So there's sometimes what happens is, you go, they'll be involved with the CDSA, or which is under DPH, so they'll be involved, and then sometimes there's that kind of drop off. So we're using this as a platform to be able to, one, make sure that our partners at the state level are aware of some of the concerns and issues that our families, our providers, and individuals served are experiencing, and trying to use this as a platform to be able to gather information and come up with some strategic ideas of how we can address some of those concerns that do come up. There's a lot to be discussed. So this is definitely going to be an ongoing meeting and engagement, just because there's just so much. And Kenneth and I are our heads around how do we get through as much information as possible in the limited time that we're coming together, and then strategizing on what we can do in between the meetings. As we talk about engagement, so kind of shift over to that question about engaging with the school system, we have, as a result of COVID, actually, we have formed a pretty good relationship with our partners over at DPI. We're trying to strategize with them to be able to address some of the issues that we know are apparent within the IDD community. The thing we keep running into is that you have the Department of Public Instruction, but then you have 100 counties that operationalize everything differently. And so it's trying to consistently come up with ways of, maybe if we can find a way to do some type of training and have some type of credits where teachers, when they go, they're somewhat rewarded, for lack of a better way of putting it, for being able to attend these trainings to educate them on things that are relevant. And then also, I think there's also a need to hear from the teachers. My sister is actually a special education teacher, and when she talks about her trainings and the value that is adding to what she does, she's like, I get more in talking to you than I do in getting from going to my trainings. So we know that there's a need, right? We know there's a need in being able to really look at different opportunities for being able to support our teachers in our school systems to be able to get the resources that they need to be able to talk about the same resources that for instance, our family navigators are able to offer. Because many teachers, my sister didn't know about about the innovations waiver, and she's been doing this for over a decade now, so it's one of those things too, on making sure that our school system is aware of some of those things, and then being able to work within the school system to address some of the other pipelines that we see, like the pipeline to guardianship. There's the pipeline to day programs. there's so many other pipelines that we need to be able to work with our school systems to address. And to start, my last thing, and then I'm gonna stop talking because I could talk about this
No,
for longer.
yeah, keep
But
going.
the other one of my biggest things that I really would like to see is more planning starting in middle school for post high school. You know, there's opportunities for post secondary education, and then there's also opportunities to work. But if we're not working towards those goals and starting our high school careers off with what we're thinking about in mind, then sometimes the planning ends up being too late, which then further exacerbates that pipeline to ADVPs or day programs. So lots of different things that we've talked about, but definitely wanting to see some more collaboration within that arena. So I'll pause because I can talk about this part all day.
Oh, no, and you're talking my language now when it comes to the schools and DPI. You and I could just have a whole off-bar conversation. I do want, and Holly's comment, you know, kind of still is in line a little bit. I don't know how many of you can actually see, you know, the Q&A, but where does the school system fit into a lot of what we're talking about? She said, there are so many that are identified through Child Find. And I know from doing a seclusion and restraint presentation recently, oftentimes schools, you know, may not be using that, but for the most part, they are identifying those kiddos. And I know, Gary, just from some of our other projects, that was something that you were trying to work on, is how can we tap into even some of the schools' data system to work hand in hand. Holly, you know, she does have some other great information in here, you know, with that process and with Medicaid. But for the sake of time, do you want to talk a little bit about that? And if Stacy and Andrew as well, anything, you know, we'll go ahead and ask Gary this piece, and then we'll go into some closing thoughts.
I think there's a lot of children who and in schools that are identified as having autism and intellectual disability that aren't visible to the medical system or the IDD system, or individuals with IDD systems or IDD systems that aren't visible to the systems. And so I think that have shared data systems to link these things. And so I do think that those are, again, at the policy level, if you could really link the data from special ed to the medical data, you might be able to find children who are not visible. So again, I think it comes back to a common, again, short of that, how do we actually communicate across sectors more efficiently? And maybe NC Cares 360 would be a vehicle for that. Again, I don't know that schools are necessarily fully a part of that at this point, but that, like, things like NC Cares 360 are very exciting as opportunities to really break down some of these data silos and connections. So,
yeah, I would agree. I like the term data silo because that's exactly what's happening. Any closing remarks, Andrew, that you would like to make?
You know, again, just thank you, and thank you all for the work you're doing. I make sure every chance I get to let people know that advocates for IDD are some of my favorite people because you're so passionate about what you do, and it's really a great your models for how we should be advocating for all people, for the well-being of all people. So I just want to thank you for that. And yeah, as I said, let's get together, let's form our value proposition, and you know, in a unified voice, take it to those who need to hear it and be educated, and pay for what. And I love the comment I saw in the chat box about pay for what we value. I think that in healthcare, that's so easily said, and it's very rarely done. So I'd like to see us do more of that while we're working on broader system change.
Great. Thank you so much, Andrew. Stacy, do you have a final closing
Yeah.
comment for us?
Well, thank you for having me. I did read in the chat and I wanted to clarify one of the big advantages I think that the family partners that have been employed at VIA, like Julie,
Mhm.
they are able to work with all families. So I really did focus on system of care, but that has been, really their value is their ability to work with all families. And because we're not held to, it's not a Medicaid billable service that they're providing. So there really are no parameters as far as who they can work with. So hopefully we'll be able to continue that going forward. And I do think that will help to have even more people out in the community making connections, like with the school systems. I think I would give us really good grades in some counties, and then other counties it's more challenging. So that sort of connection is an ongoing process. But the more you can educate your whole community, I think the more that we can address some of these populations that just are not in the system at all. And
Great.
thank you for having me. I've enjoyed
Thank
it.
you so much, Stacy. Gary, did you have any final? I know you've
Spoke a lot, so I'm sorry
picked
to,
your brain quite a
yeah,
bit.
sorry to spoke so much. No, I really appreciate the opportunity, and it's great to be part of this panel, but also to hear all the different folks across the 2 days. It's incredible, and the work that you all do is incredible. And the special thanks to Karen, I think, and Carrie, who continue to pull me in, and it's been really, I feel real privileged to be a part of it. So thank you all.
Thank you, Gary. And Latoya?
I'm just going to echo what everyone has said. I mean, thank you for this opportunity. These summits, I always look forward to them because it's an opportunity to not just hear about what is happening in our state, but it's an opportunity to collaborate and think forward. Thinking about what we want our service and support system to look like 1 year, 5 year, 10 year, 10 years, 20 years down the road. And these are the types of conversations that are needed because we know that system change does take some time. But these are the opportunities where we can come together and really start to think about what we envision the future to look like and to keep building on that. So thank you for this opportunity.
Thank you. And, I'd like to say, when I think back to that 2018 summit, to your all's point, in this great group, all of you who are listening, today, and I see the projects and how we've taken what we did learn and talk about even in 2018, and to see where we are in 2021, we really are starting to cross those I don't want to get all choked up, but I'm seeing it as a parent. I'm seeing it as a professional. When you look at ECHO and how many people are getting exposed, and that multiplicity, to the family navigation, to the NCFN family navigation project, to all the other amazing projects that everybody on this call today is working on, change is really happening. And I'm just thrilled to be a part of it. So with that, I'm going to turn things back over to, I'm not sure, Christy or Karen.
Carrie, actually, Kim. Great.
Oh, Carrie.
That's a great job. And thanks, Gary, for letting us drag you along, and Latoya and Andrew and Stacy. That was a great panel. I really appreciate Andrew's value proposition conversation moving forward with kind of my lens here. I'm going to give a quick heads up to Tamara and to Kelly, if you guys are on deck to talk about your projects that are going on, just so you guys can hear about a couple other ones. Tamara's fast and furious over here in the panel chat. And I think it'd be great for everybody to be able to hear some of the things that she's saying. So are you ready, Tamara? See your camera.
Sure. Yes, Terry, thank you.
Yeah.
Terrific conversation. So thank you so much, all of you who put together the opportunity today. And I'm really looking forward and excited about the next steps. But I wanted to share with you today a little bit about a project that Kim has mentioned several times because she's been really integral to it. And that's the North Carolina Navigating Care Project. It's funded by HRSA. The PIs on it are at UNC, and they are Becky Pretzel and Betsy Cray. I think Becky was on the call earlier, not sure that she still is. But this is a partnership with UNC and the Autism Society and the Family Support Network, with goals to increase the identification of young children with developmental disabilities and autism spectrum disorder in working with pediatric practices. We have goals to educate families and providers about ACT early signs and milestones and the need for screening, and also to create a consensus for a model and guide for family navigation for families with questions about their child's development and how to get answers and to find resources. So about a year and a half ago, a broad statewide stakeholders committee, number of you on call today, and talked about our values and our goals and what we meant by family navigation and how could we best provide the information that families need across North Carolina to get the answers that they need. So we did a lot of looking at existing family navigation guides, and there are a number of excellent ones here in North Carolina and across the country. We looked at a lot of them. We decided we didn't want to reinvent the wheel, so we didn't want to create a written guide that would be a compendium of all the services out there that families need, but that instead we wanted an online and intuitive way for families to get quickly at the answers that they need. So we have developed an online navigation guide that's in basically two parts. The first uses a decision tree model with gateway questions to help families who have concerns about their child's development, screening, or evaluation. It's a very user-friendly language, and it's in then a question and answer format that leads to tip sheets and brief answers and online resources that come from reliable sources such as the CDC. So it literally poses a question on the screen. The user answers yes, no, maybe, which takes you to a next question, which then takes you eventually to your answer. So very much a decision tree format. And then for the second part, what we've done is to consider all those other questions that those of us who work with families are familiar with, that families have once they get a diagnosis or once their child grows, once they start interacting with the complex service system out there. And so for that part, to address all of those questions, we have used the 6 life domains of the Charting the Life Course framework developed by Shelley Reynolds out of the University of Missouri that some of you may be familiar with, to categorize questions and answers in those 6 life domains that would be everything from what can I expect at the doctor's office to how can I find a welcoming faith community for my family and my child who has a disability. So again, a list of questions that are the typical questions that we all encounter. You click on that question, it takes you to a brief answer and to, again, a list of reliable online resources and places you can connect for more information. On every page, we're developing this on a website, and on every page there's a help icon. So if you click on that, it will take you to a list of all of our great information and referral services in North Carolina so that users can contact someone to speak with in person. We know that oftentimes is really helpful for families. We don't want them to get lost in information online. So where we are right now is we've been working on creating all of this content, working with our website developers. We have had family members involved in this process all along with service providers and family navigators from all sorts of organizations across the state. And we're getting really close to having it finalized and get families to review it and give us a final okay that it's both useful content and in a helpful format for them. And then we will put this all on our website and make it available to everyone. We engaged as many folks as we could in the development, but it's also going to be critical for all those folks to get the word out. We want this to be used very broadly by families, service providers, family navigators across the state. We think it's going to be very, very useful, very interesting, and we will certainly let all of you know when the announcement comes out about it. So thank you very much for the opportunity to share about that. I know everyone who's been involved has been really terrific in staying with the process. So there's been a lot of shared ownership over this, and I'm really proud of the product that we've come up with. I think it'll be really great. So we'll make sure you get the notice about it when it comes out.
Thank you, Tamara. We've really enjoyed being a part of that and look forward to seeing the end results. Kelly, you are on deck for a couple of minutes to talk about yours, if you've got time and able to get off mute.
Yep. Yes, I'd love to just briefly touch on it. I want to just talk a little bit about the peer mentor training pilot for people with IDD. We are getting ready to start the pilot in North Carolina. So this is a joint project between Optum, the National Association of Councils of Developmental Disabilities, Alliance Health, Community Bridges Consulting Group, and the North Carolina Council on Developmental Disabilities. And the North Carolina Council on Developmental Disabilities is taking the lead on recruiting, interviewing, and assisting with the selection of the peer mentor cohort. We advertised in late March. We had a 2-week open window for applicants, and we received 100 applicants exactly. We have varying diagnoses, varying geographic locations, including Goldsboro, Statesville, Boone, Barco, Raleigh, and 35% of the applicants self-identified as BIPOC. So we're really excited about the diversity of applicants that we received. We are currently in the process of interviewing. The individuals who are selected, we're looking for a cohort of 15 individuals who will test this curriculum for us and give us feedback, and they will receive compensation in the form of a $300 stipend. So really excited to include their thoughts and vision into the final training development. If you want more information, I will put a link in the chat box, and anyone can feel free to email me. So thank you all for letting me share.
Thanks so much, Kelly. Such important work that you have done over the years too. And just all the different groups that I've been in, I'm gonna have a little bit of a Kim moment. Just watching our system evolve, I think over the past, I've now been in this career for over 20 years, which is scary to say. And I'm only 12, obviously. So I think it's been wonderful to see us all kind of grow and change together and learn new things and see where we are now. And Andrew, I think you're absolutely right. We can't depend on and wait for a policy sometimes. And these great little fires that pop up of great ideas just really burn bright with folks and go far. So I think that's great. Okay, so here's what we're going to do. We obviously ran short again for the small groups, and I think that's okay because we're all in here together now. If you guys want to pop on your cameras, we can all see each other, or we can just hang out because nobody really loves being on camera all the time. And then Christy has popped in some of the questions that we were going to talk about in small groups, and we can do it through chat. If you guys, it's now open. So if folks want to go ahead and either enter through chat or unmute themselves and speak up, we'll spend the next 5 minutes or so kind of going through those questions and then close so that we end on time at 4:30 and be respectful of your time. So the first one was really, how can we expand the use of Project Echo to support more families? So feel free to just chat in some options, and that'll be something we can look, or if somebody wants to speak up, just unmute yourself and go ahead.
this is Matt Potter. I'm gonna unmute myself and speak because typing out what I'm going to say would probably take me a while, and I know we're running short on time. So I think for me, the biggest thing that can be done to help expand things like Project Echo are to continue presentations like the one that we saw today and ones that I've seen from this same cohort in the past, because frankly, I think that Echo's methods and results often speak for themselves. And so the more that people know about it, the more I think that it will be utilized. And that's my 2 cents. And I will mute to leave some time for others to weigh in. Thanks.
I really appreciate your 2 cents, Matt. I think we all do. Are there others? Any comments on that?
I'll go ahead and jump in. This is Donna Beckman with the North Carolina Down Syndrome Alliance. And I was just so thrilled to learn about the ECHO project today. And I think every organization such as myself should be utilizing this. So I think in order to be able to expand that, if we could find a way to get other organizations to use these, I think, we have a family support specialist, but we all basically do family navigation. So I think whether we have a titled role or not, organizations such as myself are providing these services. But I think if we all had Project Echo, something that we can all model and use across the state, I think that would be a great start. And I'd be happy to jump on board, and I'm going to be emailing Melinda anyway, because I was really excited to learn about that today. So thank you for sharing that.
Yeah, thanks, Donna. It's been great to start working with you this past few years too. How about the next one, unless any others? There was a question around hindering the organization, funding around the organization. Well, we can talk about that with Melinda. The cost itself is really not very much for ECHO, but it does take time, just so the cost from a capacity standpoint for sure is something to be considered by organizations, just to kind of get things up and going, like they addressed in the conversation earlier. Looking on time, can we look at some folks to chat in or to volunteer? How do we expand the options for family support services? And I know that we've talked about the in lieu of service definition that Trillium has, and that they were able to put off the ground pretty quickly. And I know that recognize that the tailored plan is in a silent period situation right now. So my understanding, and so I don't know if Michelle or somebody from Medicaid can correct me if I'm wrong, is that in lieu of service definition is available for an LME MCO or tailored plan to add to their benefit array based on funding availability, of course, as time goes on. And I think now is kind of a weird transition time between LME MCO and tailored plan. I don't know if anybody from Medicaid or the state could answer that.
Hey.
This is Michelle Mara. That's correct. Each LME-MCO has to submit, and it has to be approved by Medicaid. And obviously we are getting into the time to launch tailored plans next year. So it will probably depend on funding and lots of decisions at each LME-MCO.
Okay. So I think that's a good first step to kind of think about, but outside of a formalized Medicaid definition, which will not be available to everybody, right? I mean, because everybody's not on Medicaid or even through B3. There are still other opportunities. And so we would love to hear what those are from folks.
I have a comment on that.
Yeah.
Can y'all hear me?
Yep.
Hey, Jen Sheldon, Elizabeth City, a lot happening here. Anyway, cross delivery of services for in lieu of services for school age children. I don't understand all the logistics of Medicaid and the DPI, but I mean, that's where our underserved populations are. And I would imagine if we could just deliver navigation in a piece, aligned with the school, that would be reaching a lot more.
Yes, agreed.
We went through it during the pandemic. We couldn't support, families because of virtual school. So it's like, okay, this makes no sense. And, it would make sense.
And I think that's like Latoya said, that's where a lot of its initial conversations started to happen more with DHHS and DPI. And we look forward to that as things to keep going and certainly recognize county to county LEA limitations also. But great point, Elizabeth. Thank you.
And
Others?
also, yeah, I'd like to also say, I know, at State CFAC that they've, mentioned the Project Aware. Project Aware has the collaboration between CMS and DPI. How do we take that, framework that they've already started in that avenue of focusing on behavioral health and mental health and utilize it? Because we know we've seen tons of success in Rockingham County in their school and especially in their parent advisory council that they were able to create. So I know that is something that I think is key for families, is that it appears through my 19 years of being a parent to somebody in an EC classroom that schools try very hard to not let families communicate, collaborate, network. And so I feel like building within our school system that support network and that opportunity for families to see each other on that level and to help each other, we will see a lot more happening and change that needs to be there.
Yeah, excellent, Holly. And I think that ties to the system of care conversation, because that should, also be linking to different community groups. How can we just do a better job and learn from success just like this? So that leads me to question 3, because we're going quick on time. So what's the priority focus for the short term for any of us or our group here, the IDD Medical Health Home Group, from you guys? Like what's next on the short term, and then a couple things for the long term? I mean, I know what we're planning to do, but from feedback, we would love to hear. What should the priorities be?
Has anyone done a kind of survey of the other LME MCOs to see if they're interested in offering the service that?
Not formally.
I mean, I think that would be a great first step. Say, hey, are you interested? And if you are, Trillium's willing to help, because we heard Cindy on the call last week saying, please take this, run with it. So this is an area they could work really collaboratively, and that would be, I think, a very easy win if it's already been approved by DHHS for Trillium.
Yep. And my understanding from talking to Cindy and follow up last time, because a couple of the MCOs did reach out, was that they are developing kind of a toolkit essentially for just that purpose, Kelly. But yeah, the actual survey, to my knowledge, has not been done, not from this group anyway. Others?
I kind of feel like, because, currently with Family Navigator, it is through Easter Seals, the ARC, and Autism Society. They're already across, the whole state. How each of our own specific agencies can take it back even through, show the effectiveness with it. Yes, we are young in, getting the data of short amount of time, and of course we're dealing with COVID impacting. I think just taking that data, their presentation, that I know several Family Navigators are more than willing to support it in order to express on and the impact that it has, and take that across the state to other offices and to anybody else. Then it'd be impactful as well.
Yeah, nice. That good point, Holly, and thank you. That's been a good one together.
Go
ahead.
With our underserved, our regional health services in the rural areas, I mean, they should be on board, as well as our local DSSs. And I mean, it's really a travesty when they don't even know, what the waiver is. So, I mean, let alone, navigation. So, I mean, because that is a total break point for the at-risk families.
Yeah, good point. And there's such great comments coming up in the chat too. But I want to be sensitive about time, because it's 4:30 and recognizing nobody likes to run over. I'm sure we could all stay and talk for the evening, but let's go ahead and turn it over for some closing thoughts. If there are any closing thoughts, feel free to put them in the chat or let us know. in any other way. And then I think Lisa and Christy were going to close us off.
Thanks, Carrie. I'll just add a few thoughts. We talked last week on the first day of the summit about IDD affecting the whole family. Obviously, if we can support the whole family, we can also strengthen the whole family. And that's the value in providing these family supports, family navigation type of services. Sure, we need the data, but we know it works. At some point, we got to figure out how to get the data or how to use the data that's already out there. But this works. We know that this works. And evidence of the need is that it's popping up everywhere, right? It's popping up in the LME system. It's popping up in medical practices. It's popping up all over the place because it's a need. So I hope that that we will all be able to look back one day and talk about the days before we had family navigation and be on the other side of this and be able to enjoy having that family navigation, family support for those families who need it. As we transform this system in the next year, 2 years, and 7 or 8 years, we'll probably do it again, right? Because we'll figure out another one that we think is going to work. We got to hold on to peace. We got to make sure this becomes permanent somehow, embedded in the system, always there to make this family work. Ultimately, we know it will save dollars. It'll save stress. I love so much the visual of the woman with 8 colors on her wall, and she cannot make a decision. That's such a great example of how families get stuck when they don't have the right supports. And I'm going to hold on to that visual for a long time because it's not just about the paint on the wall. You can throw everything on the wall. It's about common sense. It's about day-to-day practices, day-to-day decisions, day-to-day things that families do that they can do better with the right kinds of support. And as we move through this and develop this, we can't leave out the people who don't have internet access, who don't have devices to get online, people in rural areas who are harder to reach. We've got to reach harder to get out to those folks. So great that we're going to put a lot of this online for people. I love that.
Everyone for all that you had to share today, all you have to offer us as we work to moving forward. I'm sorry that we weren't able to get to the breakout discussions, but we just could not stop that wonderful panel discussion and Q&A going on. It was just too important. So we do want everyone's feedback, be thinking about these questions that we put forth. It's important that we have that information available as we do our planning for our short-term actions and our long-term actions. So it's just really important that we get that feedback. Please send them to me. I put my email in the chat. We will be following up with participants about all of the information from the summit so that you have access to all the information, presentations, Q&A, and additional feedback. So again, we will be reaching back out. We want to make sure you know how to contact us and look forward to working together as we move forward. So thank you all. Take care. Have a great day, and we will talk soon.